Chapter 64, Myofascial Pain, Fibromyalgia, and Systemic Exertion Intolerance Disease. So let's start with myofascial pain. Myofascial pain syndrome is a chronic form of muscle pain. It is marked by musculoskeletal pain and tenderness, typically in the chest, neck, shoulders, hips, and lower back. Referred pain from these muscle groups can also travel to the buttocks, hands, and head, causing severe headaches. Regions of pain are often within the connective tissue that covers skeletal muscles. Trigger or tender points are thought to activate a characteristic pattern of pain that can be worse with activity or stress. Patients complain of deep aching pain accompanied by a sensation of burning, stinging, and stiffness. Examples of this syndrome include fibromyalgia, myalgia, and myositis. Physical therapy is one treatment used for myofascial pain syndrome. A typical treatment is the spray and stretch method, in which the painful area is iced or sprayed with a coolant such as ethyl chloride and then stretched. Positive results have been seen with topical patches and injection of the trigger points with local anesthetic, for example, like 1% lidocaine. Massage, acupuncture, biofeedback, and ultrasound therapy have also been shown to some benefit for some patients. Now let's go over fibromyalgia. Fibromyalgia is a chronic central pain syndrome marked by widespread, non-articular musculoskeletal pain and fatigue with multiple tender points. People with fibromyalgia may also experience non-restorative sleep, morning stiffness, irritable bowel syndrome, and anxiety. Fibromyalgia is commonly diagnosed musculoskeletal disorder and a major cause of disability. Fibromyalgia and Systemic Exertion Intolerance Disease, or SEID, formerly called chronic fatigue syndrome, share many common features. You can take a look at those on Table 64-19. It affects an estimated 2% of the general U.S. population. The disease is 4 to 10 times more common in women than men. Fibromyalgia is a disorder involving abnormal central processing of nociceptive pain input. The increased pain experienced by affected patient is due to abnormal sensory processing in the CNS. Multiple physiologic abnormalities have been found. They include increased levels of substance P in the spinal fluid, low blood flow to the thalamus, dysfunction of the hypothalamic pituitary adrenal axis, low levels of serotonin and tryptophan, and abnormalities in cytokine function. Genetic factors also contribute to the development of fibromyalgia, as a familial tendency exists. Recent illness or trauma may be a trigger in susceptible people. The patient complains of a widespread burning pain that worsens and improves throughout the course of the day. The patient often has trouble determining if pain occurs in the muscles, joints, or soft tissues. Head or facial pain often results from stiff or painful neck and shoulder muscles. The pain can accompany temporal mandibular joint dysfunction, which affects an estimated 1/3 of fibromyalgia patients. Physical examination typically reveals point tenderness at 11 or more of 18 identified sites. Patients with fibromyalgia are sensitive to painful stimuli throughout the body and not just at the identified tender sites. They may also experience pain in response to a stimulus that does not typically cause pain. In addition, point tenderness can vary from day to day. Sometimes the patient may respond to fewer than 11 tender points. At other times, palpation of all sites may cause pain. Cognitive effects range from difficulty concentrating to memory lapses and feeling of being overwhelmed with dealing with multiple tasks. Many individuals report migraine headaches. Depression and anxiety often occur and may require drug therapy. Stiffness, non-refreshing sleep, fatigue, and numbness or tingling in the hands or feet, that's what we call paresthesia, often accompanies fibromyalgia. Restless leg syndrome is also typical, with the patient describing an irresistible urge to move the legs when at rest or laying down. Irritable bowel syndrome with manifestations of constipation and or diarrhea, abdominal pain and bloating are common. Patients may also experience difficulty swallowing, perhaps because of problems in the esophageal smooth muscle function. Increased frequency of urination and urinary urgency and the absence of bladder infection are typical complaints. Women with fibromyalgia may experience more difficult menstruation with worsening of the disease symptoms during that time. A definitive diagnosis of fibromyalgia is often difficult to establish. Lack of knowledge about the disease and its manifestations among healthcare providers may also cause delays in diagnosis and treatment. Laboratory results in most cases serve to rule out other suspected disorders. Occasionally, a low ANA titer is seen, but is not considered diagnostic. Muscle biopsy may reveal a nonspecific moth-eaten appearance or fiber atrophy. The American College of Rheumatology classifies an individual as having fibromyalgia if two criteria are met. Pain is experienced in 11 of the 18 tender points on palpation, once again figure 64-14, and a history of widespread pain is noted for at least 3 months. Widespread pain is defined as pain that occurs on both sides of the body and above and below the waist. In addition, fatigue, cognitive symptoms, and extensive somatic symptoms are considered in establishing diagnosis. A subsequent classification by the ACR used non-tender point diagnostic criteria as an alternative method of diagnosis, using a symptom severity scale and widespread pain index to identify disease characteristics. It is suggested this classification be used with the previous ACR criteria. Treatment of fibromyalgia is symptomatic and requires high level of pain motivation. Teach the patient to be an active participant in the therapeutic regimen. Rest can help the pain, aching, and tenderness. Drug therapy for chronic widespread pain associated with fibromyalgia includes Lyrica, Cymbalta, and Savella, low-dose tricyclic antidepressants, selective serotonin reuptake inhibitors, or benzodiazepines may also be prescribed. If a tricyclic depressant, amitriptyline, is not well tolerated, other similar drugs can be substituted. The SSRI antidepressants, sertraline or Paxil, tend to be reserved for patients who also have depression. SSRIs need to be prescribed at higher doses than those used to treat depression. Both antidepressants and muscle relaxants have sedative effects that can help in improving nighttime rest for the patient with fibromyalgia. Long-acting opioids generally are not recommended unless other therapies are unsuccessful. In some patients, pain may be managed with over-the-counter analgesics such as acetaminophen, ibuprofen, naproxen, used in combination with a TCA, a tricyclic antidepressant. Non-opioids such as tramadol may also be used. In addition, zolpidem or trazodone is sometimes prescribed for short-term intervention in the patient with severe sleep problems. Because of the chronic nature of fibromyalgia, the patient with fibromyalgia needs constant support from you and other interprofessional team members. Massage is often combined with ultrasound or application of alternating heat and cold packs to soothe tense, sore muscles, and increase blood circulation. Gentle stretching to relieve muscle tension and spasm can be performed by a physical therapist or practiced by the fibromyalgia patient at home. Yoga and Tai Chi are often helpful. Low impact aerobic exercise, such as walking, can help prevent muscle atrophy. Patients with fibromyalgia may consider limiting their consumption of sugar, caffeine, and alcohol because these substances may be muscle irritants. Vitamin and mineral supplements may be appropriate to combat stress, correct deficiencies, and support the immune system. However, unproven miracle diets or supplements should be carefully investigated by the patient and discussed with the healthcare provider before using them. The patient should understand that some food and supplements may cause serious or even dangerous side effects when mixed with certain drugs. Pain and the related symptoms of fibromyalgia can cause significant stress. Patients with fibromyalgia may not cope well with stress. Effective relaxation strategies include biofeedback, imagery, meditation, and cognitive behavioral therapy. Patients need to receive initial training for these interventions, but they can then continue to practice in their own homes. Psychologic counseling for individuals or groups, and a support group may also be beneficial for the patient with fibromyalgia. On to SEID, Systemic Exertion Intolerance Disease. It used to be called chronic fatigue syndrome, is a serious, complex, multi-system disease where exertion of any sort, physical, emotional, cognitive, can adversely affect multiple organs in a person. SEID affects 83,000 to 2.5 million people in the United States. Women are affected more than men. SEID occurs in all ethnic and socioeconomic groups. The true prevalence of SEID is unknown because many people with the disease have not been diagnosed. Despite efforts to determine the etiology and pathology of SEID, the precise mechanisms remain unknown. However, many theories exist about the cause of SEID. Diagnosis of SEID requires that the patient have the following 3 symptoms: profound fatigue lasting at least 6 months, post-exertional malaise, total exhaustion after even minor physical or mental exertion, the patient sometimes described as a crash, unrefreshing sleep. At least one of the 2 following manifestations is also required: cognitive impairment or quote-unquote brain fog, worsening of symptoms upon standing, orthostatic intolerance. SEID is often difficult to distinguish from fibromyalgia because many clinical features are similar. In about half of the cases, SEID develops insidiously, or the patient may have intermittent episodes that gradually become chronic. Severe fatigue is the most common symptom of SEID and the problem that causes the patients to seek health care. In other situations, SEID arises suddenly in a previous active, healthy individual. An unremarkable flu-like illness or other acute stress is often identified as a trigger. Associated symptoms may vary in intensity over time. The patient may become angry and frustrated with the inability of healthcare providers who cannot diagnose a problem. The disorder may have a major impact on work and family responsibilities. Some individuals may even need help with ADLs. Because no definitive treatment exists for SEID, supportive management is essential. Tell the patient about what is known about the disease. Take all complaints seriously. NSAIDs can be used to treat headaches, muscle and joint aches, and fever. Because many patients with SED also have allergies, sinusitis, antihistamines, and decongestants can be used to treat allergic symptoms. Tricyclic antidepressants and SSRIs can improve mood and sleep problems. Clonazepam can also be used to treat sleep disturbances and panic disorders. Use of low-dose hydrocortisone to decrease fatigue and disability is being studied. Advise the patient to avoid total rest because it can contribute to the self-image of the patient as an invalid. On the other hand, strenuous exertion can exacerbate the exhaustion. Urge the patient to plan a carefully graduated exercise program. Also, encourage a well-balanced diet, including fiber and fresh dark colored fruits and vegetables for antioxidant action. Behavioral therapy may be used to promote a positive outlook as well as improve overall disability, fatigue, and other symptoms. Loss of job often leads to a loss of medical insurance. Obtaining disability benefits can be frustrating because of the difficulty establishing a diagnosis of SEID. Recovery is more common in persons with sudden onset of SEID.